Hello, my name is Apoorva Mandavilli. I'm a reporter at the New York Times where I focus on mainly science and global health. Today we are talking about HIV, TB, malaria, and diseases like that we have maybe not been paying quite as much attention to. Last summer, I wrote a story for the New York Times in which I interviewed a doctor who normally practices in very remote parts of Brazil. And he said something to me that I will never forget, which is that the biggest monster is coming, and it's not the coronavirus. And he was referring to TB, which kills 1.5 million people a year. When a country like India or Brazil is battling a pandemic, as those countries are now, what happens to all of the other diseases that they have to grapple with? TB, malaria, polio, HIV. Today, we have a great panel to talk us through what's happening on the ground in many of these countries and what the future looks like. Our first panelist is Dr. Tim Anderson. Tim, can you say hello?
Hi, I'm looking forward to the session.
Tim is the program co-lead for disease intervention and prevention at Texas Biomedical Institute, where he focuses on the genetic basis and evolution of biomedically important traits in two of the most important human groups of parasites, malaria parasites and parasitic blood fluke responsible for schistosomiasis. He has 30 years of experience working in parasitology. Our next panelist is Lisa Goldman Van Nostrand from Sumitomo Chemical. Lisa?
Hi, pleasure to be here.
With a career spanning technology, design, entertainment, global health, and humanitarian sectors, Lisa manages cross-cultural, multidisciplinary teams to achieve high-impact, creative, and strategic advocacy results. Since 2004, her focus at Sumitomo Chemical has been on malaria advocacy and governance, with projects ranging from the creative, including photo library development, mass broadcast concerts, and public service campaigns, to public-private partnership governance and board support. Sumitomo is one of Japan's leading chemical companies and a pioneer in the development and innovation of new vector control tools for public health. Our next panelist is Dr. Anja Giphart of the Elizabeth Glaser Pediatric AIDS Foundation. Anja?
Hello, happy to be here.
Anja is the Executive Vice President of Medical and Scientific Affairs at the Elizabeth Glaser Pediatric AIDS Foundation, where she's responsible for providing technical leadership and direction for the long-term strategic vision for the foundation's implementation, technical assistance, innovation, and research initiatives. She's responsible for furthering the foundation's leadership in pediatric and adult HIV/AIDS, TB, and other comorbidities and health threats by developing, maintaining, and expanding the depth and breadth of relationships with key governmental agencies, multilateral organizations, and other strategic partners. And finally, we have Karl Hofmann from Population Services International. Karl?
Hi, Apoorva. Thank you.
Karl's the president and CEO of Population Services International, which is a nonprofit global health organization. PSI operates in over 50 countries worldwide with programs in family planning and reproductive health, malaria, water and sanitation, HIV, and non-communicable diseases. PSI works in partnership with local governments, ministries of health, and local organizations to create health solutions that are built to last. Tim, I invite you to start your presentation now.
Thank you very much, Apoorva. So at Texas Biomed, my lab works on schistosome parasites and malaria parasites, which together cumulatively infect about 400 million people. So at the height of the pandemic in Texas, I called up my collaborator who works in Western Kenya on the shores of Lake Victoria. And I asked him about the impact of the pandemic in Kenya. And his response, well, actually, COVID is rather far down our list of priorities here. We've just had enormous flooding and we're worried about a surge of malaria cases. And he said, and we have an enormous plague of locusts. We're worried about food shortages. And he said, but because there are restrictions on travel and et cetera in Kenya, he was very worried that they were going to have to delay their mass drug administration for treating schistosomes. which are a major problem in that part of Kenya. And he was worried that this was going to really push back their efforts to control this important neglected tropical disease. So I think this illustrates the fact that if you read the US press, you wouldn't think there were any other diseases afflicting the planet, but there is a whole suite of different diseases. And we're talking about the big three: TB, HIV, malaria, that together kill an estimate, 2.5 million people every year. That's very close to the numbers that have died from COVID during 2020, and they kill year in, year out. We're talking about the neglected tropical diseases, schistosomiasis, and a whole range of helminth parasites. We're worried about diseases like polio, which we're right on the cusp of eradicating. But the concern is the pandemic will actually allow polio to reemerge. There will be a lack of political will to actually continue it, and that opportunity will be lost as a result of the pandemic. So there's a whole suite of disease control problems related to coronavirus. So let's just highlight a couple of diseases. So TB is something certainly that has been hard hit. TB control relies on case detection and then quite a lengthy program of treatment. And you can see on the graph on the left that there has been a dramatic decline in the numbers of TB cases detected. That's not because those TB cases are not there, it's just they haven't been found and those people are no longer being treated. And there are 500,000 extra deaths that have resulted from that failure to detect those cases. In the case of malaria, we've actually been doing fabulously well in moving towards elimination. We've reduced deaths by half since the turn of the century. In this case, there's a real concern that a lack of access to medicine and bed nets will result in a return to the kind of mortality that we saw at the turn of the century. I think other speakers will talk about this, and the people involved in control have actually been very nimble and they've adjusted. And in fact, the excess deaths have not reached these dire predictions. But I think it illustrates it's a delicate balance. But what are the kind of issues then? So in the case of malaria, there's obvious issues with access to drugs, with restrictions on international travel and local travel that cause issues. There's less obvious issues. During the beginning of the pandemic, there was a massive rush on masks. N95 masks are critical for indoor house spraying to eliminate malaria vectors. And they were in critically short supply, and that was a real interruption. When there was enormous enthusiasm and presidential endorsement of hydroxychloroquine, there was a rush to buy up the precursor chemicals to actually make that drug. But an issue here is those same precursors are needed for making critical anti-malarial partner drugs like piperacin and amidiaquin. And that again caused changes in prices and availability and was a sort of unexpected knock-on effect of coronavirus. I think we should actually end on an optimistic note. What are the good aspects of COVID-19? Certainly, with all this mask wearing and social distancing, we expect a reduction in respiratory infections. And certainly the flu season has been very quiet across the world. We've also seen very few cases of measles, despite a big reduction in vaccination rates. When pandemics or other diseases move close to Washington, there's automatically increased awareness and funding available for disease control and research. And we hope after the pandemic that will actually spill over into attention for these other diseases. The pandemic has spurred fabulous innovation in vaccine development and other aspects of healthcare implementation. And again, we really hope that this will spill over into new innovative approaches to tackle these other critically important infectious diseases. Thank you very much.
Thank you, Tim. That was so interesting. And I love that you ended on a positive note, but also that you talked about some things that we don't really think about very much at all in this country, like schistosomiasis or locusts. Those are not things that really come to our mind. Lisa, we'd love to hear from you next.
Thank you so much. I just wanted to set the scene on where we are with malaria. And I think many people don't realize that malaria used to be endemic pretty much around the entire world. We've made incredible strides in the last decades with reductions. We have saved probably 7 or 8 million lives and averted 1.5 billion infections just in the last decade. And last week, the WHO announced 27 more countries that could eliminate malaria by 2025. But well before the COVID pandemic hit, we had already hit a plateau in some of the highest burden areas. So you might ask, well, since we've made so much progress, can't we just pause there while we deal with the pandemic? And unfortunately, the answer is no. Experience shows that basically anytime you interrupt a malaria campaign, it resurges very quickly. People lose malaria immunity very, very quickly. And so it can turn into basically a COVID pandemic every year when there's an outbreak. So you can't stay in place with malaria. It's either moving forwards or moving backwards. And complicating things even further is that COVID and malaria share a lot of the same symptoms, especially fevers. COVID has 7 out of 10 of the primary symptoms of malaria. And in the rural areas where malaria programs are the strongest, this, prevention and treatment of malaria can keep fevers out of the system and help prevent misdiagnosis. People also don't want to go into health clinics when they're worried that they might catch COVID there. So all of these factors have combined to make the frontline workers for malaria even more important. I just wanted to share this information from the Global Fund to Fight AIDS, TB, and Malaria, which is tracking very closely to see how COVID has interrupted the programs. Malaria is the line in yellow on the bottom. And, Tim showed earlier the concerns that malaria deaths could double with the pandemic. We averted that so far. In 2020, about 90% of malaria campaigns were able to be delivered. But we see in 2021 that those achievements are very fragile. And so it may not continue in that way. All of this has just gone to show us how reliant we are on community health workers who are on the front lines. So these are often unpaid workers, but they're able to keep a lot of fevers out of the system, and they're really playing a vital role in global health security and keeping, all of us safer. So I think there's a lot more recognition of the critical role that they're playing these days. And that's what I wanted to cover up with that. Thank you.
Thank you, Lisa. The malaria COVID overlap in symptoms is really striking. And the idea that you don't just stall forward movement, but actually lose previous progress and go backwards is really disheartening. Anja, we'd like to hear from you next.
Yeah, thank you very much. For those of you who don't know the Elizabeth Glaser Pediatric AIDS Foundation, our mission is to end HIV and AIDS in children, youth, and families. And we do this through research, program implementation, advocacy, and technical assistance. After more than 30 years, we still continue with our focused mission because daily, approximately 400 children get infected 40% of the children who are exposed to HIV do not receive an HIV test in the first 2 months of life. And though that's important to do it that early, because undiagnosed, half of the children infected with HIV die by the age of 2 and 80% by the age of 5. Also, of the 1.8 million children currently living with HIV, half of them don't receive life-saving treatment. And those who do, 1 out of 3 are not virologically suppressed. One major reason is that they receive suboptimal pediatric formulations. And then for adolescents and youth, many of you know that HIV is the #1 death, especially in sub-Saharan Africa. So because of this burden of disease focused mostly on sub-Saharan Africa, that's where we work. We have activities in 17 countries with about 3,000 staff in 11 countries. And while our focus is very much on HIV and TB, we do this in an integrated manner, and therefore we also support sexual reproductive health services, child health services, and health system strengthening. For example, strengthening laboratory services, supply chain management, and training of healthcare providers, and secondment of staff in health management teams. And just to give a quick idea of our footprint, just in 2020, we supported 9 million HIV tests. Together with our 3 affiliate organizations, we support 1.7 million people on ART, of which 100,000 children. COVID has had a significant impact in the work that we do. As already mentioned by others earlier, due to travel restrictions in countries, fear, stigma, we saw a reduction of clients coming to the facilities. Also, the services themselves were limited because some of the facilities were closed and repurposed for COVID care. Some of the services were reduced to make space for COVID care. Service providers sometimes were absent to come to work because of the travel restrictions. And then we had also in a number of countries where service providers were working in shifts to limit the number of people present at once in the facility. We also saw a significant impact in logistics. For example, we saw drugs and diagnostic stockouts because borders were closed, intercontinental traffic was restricted, and in some cases, even factories stopped producing altogether. The impact that we saw of COVID was different in the different countries where we work, depending on the severity of the epidemic, as well as the measures that the government took. But overall, there were definitely significant impacts. For example, we saw across our countries a significant decline in HIV testing and ART initiation up to 25% between January and April last year. In Uganda, we saw a 50% decline in early infant diagnosis by the end of May compared to the beginning of the year. And in Cameroon and Cote d'Ivoire, we saw a 30% decline in HIV-infected pregnant women newly initiated on treatment, which obviously has repercussions for the health of the woman as well as transmission of mother to child of HIV. And then we also saw a delay in the introduction of new child-friendly pediatric formulations. So altogether, it was a significant impact. What did we do together with the Ministries of Health to adapt to the new situation and to try to continue as much as possible the HIV and TB treatment? So we changed patients' flows in facilities and initiated triage stations outside the facility. We moved patients from monthly visits and monthly pickup of drugs to multi-month dispensing, meaning that only once every 3 months or only once every 6 months they had to pick up their medicine. In a few countries, we were able to add a significant number of clients using HIV self-testing instead of coming to the clinic. And then we did a lot of virtual follow-up with clients through phones and WhatsApp, virtual supervision, and training and mentorship. So since we already have a presence in the 11 countries, as I mentioned, we also started supporting the Ministry of Health across the countries with COVID-specific activities. For example, training of lab staff, training of healthcare workers in sample collection, COVID testing, sample transportation, triaging and COVID care, and vaccine preparedness. In Malawi, we support the ministry with a national level surveillance, and we do in a number of country operational research to really determine the impact of COVID. As Tim ended, I also think there is a silver line in all of this. What we saw, for example, is that there was a much quicker adjustment of policies because of COVID. For example, the multi-month dispensing for children, adolescents, and pregnant women normally would have taken much longer. It was only for stable adult patients. And because of COVID, everybody recognized the importance of this, and we were much faster able to adapt that. We've also seen the use of technology and digital solutions really moving rapidly into a positive direction. Point of care diagnostics have really proven their value during this time of COVID, and we believe this will help with further scale up for viral load, for early infant diagnosis, for TB diagnostics. And then I think also very important is that client-centered care has really hit home much more than before. I think we were all talking about this for quite a while, but really COVID has forced us to do things differently and to think outside the box and really looking where are the clients, what do they need, and how can we adjust our services away from our traditional facility-based model to really focusing on where we can find and serve the clients. And then finally, I think as an international organization, it has also really made us think much more what is the role of an headquarters in the United States with our teams in 11 different countries. Before, we used to travel obviously very often to our country programs. And although there are certain activities that could not be done, I think we've also seen that a lot of things have continued to happen without us traveling, without us having to be there. So I think for us as an international organization, it has also really created an opportunity to think really critically about our own role. So let me stop there. Thank you. I hand it back to you, Apoorva.
Thank you, Anja. It's so interesting that there are so many unexpected knock-on effects of lockdowns and travel restrictions on diagnosis and care for HIV and TB, good and bad, and especially on women and children. That brings us to Karl, who will talk specifically about the effects on sexual and reproductive health services. Karl?
Thanks, Apoorva. Yes, it's interesting to see how all these narratives really overlap a lot, and also how obviously the topic at hand is disruption, but there are so many opportunities that come out of this moment too. And we're seeing some of my panelists here discuss them already, and I'll add a few to that. I agree with everything that's been said about the disruption, certainly to malaria and HIV. But as you noted, we haven't really talked much about the effects on reproductive health and rights. Now, it's not a disease area, but it's certainly a health area. I would say this, in normal times, we know that it's a narrow and a closely fought thing for women in many parts of our world to have the ability to control their fertility in ways that they like. And clearly the pandemic has made that effort even harder. The necessary reduction in service delivery, for example, because of COVID concerns, has denied women access to long-acting contraception, and disruptions in supply chains, as Anja noted, may have also disrupted access to short-acting methods, such as oral contraceptive pills. I mean, my own organization, a nonprofit, we're a social marketing organization, we sell a lot of contraceptive products, condoms, oral contraceptives, emergency contraception. Not surprisingly, in 2020, our social business took a big hit. Now, that could all mean less sex, but it likely means, instead of, or at least in addition to that, more unintended pregnancies. Expectations at the start of all this a year ago were that the pandemic would yield some sort of a baby boom for these reasons. And I think it is clear that health conditions, particularly for women in the global south, have been made much worse. We don't yet have much evidence of a baby boom. And in many cases, we may have evidence of the contrary. But the evidence is fragmentary. And probably incomplete to draw any conclusions at this point. The UNFPA, however, did say recently, 1 year into the pandemic, they estimated an estimated 12 million women have seen contraceptive interruptions as a result of COVID, leading to 1.4 million unintended pregnancies. That's according to UNFPA. And we know in normal times, even pre-pandemic, there remain in excess of 200 million women globally who want access to modern contraception to space or limit their pregnancies, but who don't have that access. And that challenge has confronted the global health community and national governments for many years now. So despite new investments and attention to meeting unmet contraceptive need over the last decade, the gap still remains. But let me perhaps also take a page from my fellow panelists to talk about some positive innovations in this area that came out of our COVID moment. And like so many organizations, PSI undertook hundreds of program adaptations across our programs to deal with COVID in the various health areas of intervention. The toughest areas, of course, to adapt and remain safe are in terms of safe delivery of quality services, whether in voluntary medical male circumcision, for example, as an HIV prevention strategy, or in IUD insertions or what have you. But on the flip side, as Anja noted, digital approaches undoubtedly have been really robust adaptations, I think, for all of us. We've seen great uptake in consumer-facing, but also health system-facing applications of digital tools, such as training. We have a program called Adolescence 360 that's working on adolescent sexual and reproductive health in 4 countries in Africa. And we've been using Facebook and WhatsApp and have really ramped that up to reach our target audiences with information and referral services around sexual and reproductive health. We've had to do that much more than what we would have done previously in terms of person-to-person interactions. But the interesting thing that we've seen across 4 countries of intervention, I should say, that's Tanzania, Kenya, Ethiopia, and Nigeria. So we've actually had an increase in 15 to 19-year-olds reporting access for the first time to contraceptive services. And that's been driven through the digital approach. So I doubt we're ever going to go back to what we would have called normal prior to this. There's clearly a lot more to be gained from a more intensive digital interaction with our consumer base everywhere. In safe abortion programming in Madagascar, we undertook bulk deliveries to certain wholesalers and pharmacies of misoprostol, which is a life-saving drug used in post-abortion care, in order to avoid the stockout phenomenon. And we were really interested to see a significant uptake of this product, way above normal demand. Now, is this because of lack of access to more traditional MVA abortion care, or an increase in abortions due to lack of contraceptive access? We just don't know that yet. But it was interesting to see a real uptake through a pipeline that we were able to stock early on. In Southeast Asia, we're funded by the Gates Foundation to work on malaria elimination strategies in the greater Mekong subregion. And you saw in Lisa's maps there, you could see as malaria incidence has declined across the world and over the years, the bulk of it, or the reddest parts of the map, are still in Africa. But if there is to be a breakthrough against ACT, artemisinin combination therapy, which is our real ace in the hole against malaria treatment, it's probably going to come in Southeast Asia. So that's why there's a real focus on trying to prevent that resistance of the parasite breaking through in Southeast Asia. And we've been funded by the Gates Foundation to create sort of an emergency operations center working with national governments in Laos and elsewhere to track incidents, in this case of malaria. But it turns out, surveillance, targeted response, rapid tracking of outbreaks, we were doing that with a malaria focus with this emergency operations concept. But that's what we need for any pandemic, this pandemic, the next pandemic, and future pandemics. So COVID has reinforced, I think, some real building blocks of health systems strengthening across the world. And the final point I'll make, and I want to come back to something that Anja said here, COVID has meant, I think, highlighted a breakthrough and emphasized an important trend that's been underway and in development across the global South, but really has the potential to leapfrog over a dysfunctional primary healthcare system that's been there for years, and that is self-care. That's self-diagnosis, because there's more capable tools available for that, self-administered therapies. This is true in terms of long-acting contraception. It's true in terms of HIV self-testing. It's true in terms of medical abortion. There was an article in today's Washington Post about a widespread experiment underway in a county somewhere in North Carolina to really push COVID-19 self-testing out to the entire community and really make that an expected way to continue to track progress against the pandemic. So I think we're seeing a lot of examples of how self-care really is finding its moment. Shouldn't surprise us. When the traditional healthcare system is sort of off limits because of concerns about safety, turns out we can put much more healthcare decision-making in the hands of consumers, and we ought to find ways to do that when we come out of the pandemic as well. You can't overcome the need for a provider to insert an IUD, but for many other health interventions, self-care and consumer power is a key to progress, and I think the pandemic has highlighted that. Back to you, Apoorva.
Thank you. That was so interesting. And also, again, I really like the optimistic take, but I hope that it's not just governments and consumers, the average people that are learning some lessons from this pandemic to prepare for the next one. I hope federal governments are taking note as well. Now I'd like to invite all the panelists to join us back so that we can ask you some questions that really help us, get into the details of what you've been talking about. So COVID has affected so many different health issues and so many aspects of each of those, and you've all been talking about some of those. And we obviously can't do everything, given limitations in money and people power, and especially political will. So where should most of the energy go, and what's taken the hardest hit? What's the most urgent? And what do we need to get there in terms of money and support? And this is a question that's open to everybody, but maybe we can begin with Tim.
Okay, I think really it's very disease dependent. So if you're talking about a disease like measles, I think a great deal of investment in vaccination and making sure coverage is sufficient is probably a really, really effective tool. If you're talking about malaria, it's much more difficult in that certainly prevention, like using bed nets, is critical. But access to treatment is equally critical. I think you can see a sort of nice example of how important that is from the Ebola epidemic in West Africa, when more people actually died of malaria from disruption and lack of access to healthcare than they did from Ebola itself. So it was because people didn't go to clinics, they didn't receive the treatment they needed to be cured. So yeah, and I think perhaps another point to make here, it's not a dichotomy. I think for many diseases, I think people accept that really there is no magic bullet. We need to use several different approaches. And I appreciate your question sort of said money is limiting, but if there can be strategic alliances between different disease control programs, so we can save money in that way, we can actually use multiple approaches.
Karl, you seem like you want to say something.
I wanted to add to that. I think, many of us have referred to, and a number of us, maybe all of us, work with or have worked with the Global Fund for AIDS, TB, and Malaria, which has been a big driver of progress over the last 2 decades, right, in those 3 critical disease areas. I used to think to myself, or I used to say, it's great to be able to mobilize the resources that have been mobilized against those 3 diseases because we can track progress, because we understand them. But there's never going to be anything like a global fund for health system strengthening because that's just too squishy. Well, I could have been completely wrong. We're at a moment now where there are significant resources being unlocked, particularly now that the US government is really getting back into gear for a response to COVID. And so much of it passes through recognition, I think, that we need a strengthened health system globally, that the weakest link anywhere is a weak link for all of us. And so we may be getting to a point where those resources, constrained as they are, can now start to be used more horizontally or diagonally as opposed to always vertically, because we know it's the horizontal piece that we've really relied on or seen the absence of.
Right. Lisa?
Yeah, I just to add to that, I think, I think the frontline healthcare workers are the ones that are, more and more, as you were talking about self-care, Karl, being able to diagnose and treat, keeping those supply chains open, being able to keep fevers out of the system so that you don't have to wonder if it's COVID or malaria or something else or a headache. So I think that, the countries that have the strongest investments in these frontline healthcare workers have also done really well against COVID so far. Like Rwanda is one of them, Uganda, Vietnam. So I guess I think we're seeing more impetus towards integration. I know, like with malaria and other neglected tropical diseases, there's a lot of discussions about how we can use that frontline capacity more effectively together.
Anja?
Yeah, I think most of it has been said. I think integrated healthcare system focus, that's key. That patients also don't come with one disease, right? And even if they do come with one disease, the differential diagnosis is often a number of diseases that we're been talking about. So I think indeed integrated healthcare systems needs to be the focus. I also think a public health approach is really important. And you asked about where should the priority be on prevention, care, treatment. I think the priority still should be on prevention. And that's more difficult to measure. And it goes back a little bit to what Karl said with health systems. We struggle with measuring prevention and the impact of that. But in the end, I think that's where the biggest bang for the buck will be. So,
Lisa, in your talk, you talked about actually going backwards. And I've seen some estimates from organizations like Stop TB saying, we've lost a decade of progress, or we've lost 12 years of progress. What does that mean? First of all, how does one even arrive at a number like that? And what do you think we've lost? How can you tell us what the damage is in terms of years lost?
That's a really hard question to answer. I think, countries and their health partners are really scrambling to prevent that backsliding. The latest model I saw said that over the next 5 years, we could see about 36% increase in malaria deaths. So we've certainly avoided what looked like a year ago. The models were showing that there could have been 800,000 malaria deaths in 2020 alone. That didn't come about, but it was because of heroic efforts. And much like others were describing, usually when you're distributing bed nets or other malaria commodities, it's the whole community comes out. It's very crowded. It's often celebratory. It's an event. And that had to totally change to, achieve these distributions. So, all these workers had to have, PPE and go door to door with bed nets. Now, one bale of bed nets weighs about 50 pounds. So you can imagine what that feels like. So it's been very complicated and heroic efforts, I would say, but the answer remains to be seen, Apoorva.
Tim, do you have thoughts about this one?
Yeah, sure. So, I think it's really too early to say. I think we're not through this pandemic yet. We think we're on the tail end in this country, in the States, but it's ramping up in India. And I think currently only 3% of cases of COVID are in sub-Saharan Africa, but we're seeing that change now. So they are really possibly at the beginning, and we really have no way to know at the moment what the impact is going to be. And I think the other thing to really point out is the impact, again, is incredibly disease dependent. So to take an example from all the intestinal helminths and schistosomiasis, all of those diseases, there is no vaccine. So control is through sort of periodic mass drug administration. And the rate of rebound of infection after treatment is what will really determine how badly affected those programs are. In the case of hookworm, I think the rate of rebound after treatment is quite slow. So if we perhaps miss a year of mass drug administration, that may not have an enormous effect on hookworm. In the case of schistosomiasis, on the other hand, there's very rapid reinfection. So missing an episode of mass drug administration can be a real setback. So I think for those kind of diseases, very, very disease dependent. And I think there's also the politics. Again, if there are setbacks, if there is a loss of political will, if people think, if there's a big resurgence that this problem's too hard, we're going to put our money elsewhere, then, the setbacks may be much bigger. On the other hand, if people are suddenly enthused about what we can do with global health, we may actually accelerate things. And finally, perhaps one more thing to say there, I think the other part of this equation is the economic effects of this pandemic. I think are estimated to put 100 million more people into poverty, and I think that's sort of with a $2 a day kind of expenditure, and poverty comes with a whole suite of infectious disease challenges. So that's another thing that has changed and will have sort of long-term ramifications. Thanks.
I mean, I certainly take your point about it being too soon to tell, because I think we all thought India was maybe done. And here we are in the middle of the pandemic, and I'm sure that's going to have a massive effect on their TB efforts, especially. Anja and Karl, you both talked about the effect on women and children, especially, and women and children seem to often bear the brunt for many things, especially in certain countries. And I wonder if you could talk a little bit more about that. Maybe Anja, you could begin.
Yeah, sure. From our program data, what we have seen, the biggest impact has been the identification of children infected with HIV. And there are a number of reasons for that. First of all, for the central laboratories, quite a number of them shifted their focus on COVID. So the services for early infant diagnosis were therefore very limited. We've also seen in some of the countries the shortage for the point of care cartridges created limited possibilities for children to get tested. And then, of course, we have the reduced attendance, as we talked before, for why clients just didn't come to the facilities. And then for older children, they often get diagnosed through index testing, which means we use a newly diagnosed client to line list their children or their siblings and then test those children. And since we've seen fewer newly diagnosed individuals and then subsequently limited work that we could do at the facility or in the community, children are the first ones to be dropped. So we've definitely seen from our program data that children have been impacted significantly more than adults, for example. And then I think the point that Tim just made around the economic impact, we also all know, of course, that when there is less money in the family, it's the women and the children first who will suffer from accessibility to services, because even if the services are free, there's often still a cost to the client because they have to travel to the clinic or they have to stop other activities that they otherwise would do. So yeah, that we've definitely seen the biggest impact of our population has been on children.
Karl?
I remember early in the onset of this, as all of us were grappling for some handhold on what COVID was going to mean and how it was going to manifest. And I remember some hopeful commentary about how, well, at least it doesn't seem to be affecting kids directly, at least as much as it was adults. And that was, I think, true, although we see in the US now the picture may be shifting somewhat. But we can, if we look back to the early phases of this was, COVID direct effects were obviously much more on adults. The indirect effects, economic, educational, and so forth, are obviously profound in terms of the disruption on societies and on communities. And as you said, the premise of your question is, sure enough, women in particular, but women and children in general, suffer disproportionately anytime there's disruption or problem in the society. And I think there's no doubt that we've seen that manifest itself in a lot of ways. I saw something from the WHO the other day indicating that, in terms of routine vaccination campaigns that normally would be underway against childhood illnesses, something like 60 mass vaccination campaigns in 50 African countries right now are on hold because of COVID. So we can expect the effects on children to show up in subsequent years in ways that are hard to quantify right now. But it's pretty bad. It's pretty bad.
Some of you have mentioned different countries in talking about this, and there have been some unexpected surprises. Well, maybe at least in the global north, there have been surprises to see. For example, you mentioned, I think, Lisa, that was you, that Southeast Asian countries have done, some of them have done well. And Tim, you mentioned that Sub-Saharan Africa has not yet seen a pandemic. That could change, I suppose. But overall, how would you say that the effects on all these other diseases and the mitigation efforts will vary across the world, in different parts of the world? Lisa, do you want to take this one?
Well, that's a tough question. I don't. I think that countries that have had a strong culture of mask use have obviously had an advantage coming into COVID. We've seen, I think, here the challenges of adopting mask use, where here in the U.S. is not so common before. So, I think what we've seen from the malaria perspective is just that where you have strong health systems already out in the field in rural areas, those have been able to be adapted. If you're able to go out and test for a fever, to identify an emerging threat before it becomes a bigger threat, those are the elements of pandemic preparedness that are common across, I think all the areas that we're working in. But, to that extent, I think many African countries have really responded well. I mean, look at, I won't, take any off the top of my head, but they have experience with dealing with more recent pandemic or outbreaks than we do here in the United States. So I think they've really modeled what we should all be doing in some places.
Yeah, I remember reading that South Africa was using some of the systems it had in place to deliver HIV medications. These community networks were actually coming in very useful during COVID. There's some unexpected benefits to having had to deal with so many other diseases in the past. Tim, do you have something you'd like to add to that?
I can just add perhaps another example. So I work closely with people in sort of eastern Myanmar on malaria elimination that Karl was actually talking about earlier. And they've set up a really impressive system of sort of village malaria posts, which, have been incredibly effective at malaria case detection and treatment. So have been well, just very, very impressive. But they've been sort of repurposed now, also for early detection of COVID. And I think, again, it's an example of places that are actually used to working with infectious diseases and are quite able to pivot quickly to face, just one of many challenges. So I think many places like that will do very well. I think I'll leave it there. I think there's a whole load of countrywide factors that really, I think, influence how countries respond. So I think in the initial talk between Barbara Bush and Larry Schlesinger, they were talking about aspects of countries that fail with COVID and succeed with COVID. And I think, again, those same kind of factors will be related to succeeding with malaria or failing with malaria or other infectious diseases. Thank you.
We've been hearing that diagnosis is one of the biggest problems, and just getting people to be diagnosed with TB or with HIV is a big issue to begin with. And I've certainly been hearing about how the gene expert machines have all been used for TB, that were used for TB are now being used for COVID. So what impact do you foresee of that for late diagnosis and therefore more severe disease, but also for people who have been diagnosed but can't get care? Do you expect to see more drug resistance? And Anja, can you take that question?
Sure. Unfortunately, yes. We haven't seen concrete data yet what the COVID impact is, but we do know with treatment interruptions there is definitely an increased risk of mortality and drug resistance. So, and we do know that in certain places, either drugs shortages made it that people did not get any drugs, or they were shifted back to less optimal regimens to cover them through the period till the better drugs were available again. So we definitely expect that, but we have no concrete data as of yet related to COVID.
And what about the effect from diagnosis, the lack of diagnosis?
Yes, again, I think if we look at our own program data, we see that the biggest impact has been either the point of diagnosis or diagnosis linked to treatment, where it looks like we have done better because of some of these inventions that we talked about earlier, like multi-month dispensing. It seems that those who are on treatment, we have done a relatively good job in keeping them on treatment. Although the real issue we will have to see as well, because if you give somebody 6 months drugs, you don't know for sure that they take it for 6 months and that they'll come back after 6 months. So, but at least I think there seems to be a less of an impact than really the point of diagnosis and then the linkage from diagnosis immediately to treatment. That's been more affected.
I don't want to neglect the neglected diseases here. So Tim, could you address what you're seeing, not just for schistosomiasis, but maybe if there are other NTDs that you've seen that are not on the horizon as much, not being discussed as much as maybe the big three? Well, you're on mute.
Can I just make a quick comment on drug resistance?
Please.
So I think, one of the most effective ways to stop the spread of drug resistance is to stop treating. Stop treating populations. One of the impacts of the coronavirus epidemic seemed to be less people are being detected and less people are being treated. So you would expect that actually to retard spread of drug resistance in pathogen populations. But on the other hand, as Anja was saying, if you have a patient on a complex regimen of combination therapy and they don't stick to that regimen because they're not being properly supervised, then you're more likely to have emergence of resistance. So there's kind of two sides to the coin here a bit. Yeah, so you wanted to, the question was about the neglected tropical diseases.
Right. The smaller diseases that often get ignored.
Well, I think the big thing to say here is, they may not make the front page of the New York Times, but they are out there, and all of these infections do infect actually billions of people, and they don't tend to cause enormous direct, they're not directly related. It's difficult to quantify direct mortality from these diseases, but they have a massive impact on health. So we know with, for instance, schistosomiasis, we know that people who are infected with schisto are more susceptible to HIV, have faster progress to HIV/AIDS. So, really, any delay in trying to in control of these diseases will also have massive knock-on effects for other other diseases. So I think it's critical that we just don't forget these are they may not be glamorous, but they have an enormous impact on global health. We really need to keep a focus both on the big diseases and all those other neglected tropical diseases. They're neglected but extremely important.
I take your hint. I'm going to try very hard to get it on the front page. Lisa, do you have anything to add to that?
I do. I just want to add that there are millions of people who suffer from NTDs who are. And it's anything but easy. They're really horribly painful and can be really disfiguring and terrible things to live through. And we've seen these campaigns interrupted. We know that they're interrupted. I think depending on the disease, I understand that some mass drug administrations, some will bounce back more quickly. Others take longer before they resurge. But we've seen funding cuts coming out of the UK now for NTDs that are just being announced. And, they're about a third of all NTD funding comes from the United Kingdom. And so there are millions of people in like 24, 25 countries that are at risk from those diseases. So as much as they also impact other diseases, they also have a really profound impact for the people who are at risk of them. So I think on the malaria and NTD side, there are new organizations, like there's a new Global Health Institute in Abu Dhabi called GLIDE, Global Institute for Disease Elimination, that's actively exploring how can you integrate disease elimination campaigns for multiple diseases and looking at this. But I think it's one of the impacts of, the pandemic is that there's always been talk about the need to integrate our different health silos, but there's a lot more, it seems like a lot more of that is happening now out of the sheer urgency of combining our efforts.
Apoorva, I wonder if I could ask Tim just a clarifying question on something as our NTD champion here. I mean, we had hydroxychloroquine be in the limelight for way too long. Apparently, ivermectin is also in the limelight now. I wonder if we have yet an indication of how this, what appears to be misguided focus on these two and perhaps others as COVID therapies, what effect is that having on their primary purpose in the fight against NTDs? Do we know yet?
So I'm afraid I know nothing. I've just seen, everything going around on Twitter and the web, but I can't comment on what actual effect that's had on the ground. Yeah. But I think it is it's a real concern.
I don't know about ivermectin, but I know that last year there were actually real problems with hydroxychloroquine. People couldn't get their hands on that because there was such a big demand.
Yeah.
So I wonder if I could just perhaps again, follow up on the neglected tropical diseases. I think that's really a case where political will is an issue. In the case of schistosomiasis, I think we were on track to really eliminate schistosomiasis as a disease, as an impact on human health by, I think, 2025 to 2030. We're doing quite well. And so I was really sad to hear Lisa saying that actually there is now withdrawing of funding, and that, that's precisely what we want to avoid when we've got momentum, and if we want to keep that momentum. So,
well, since you brought up political will, we have a president now in the White House who does seem to embrace science, and it looks like he's going to make a pretty big commitment to PEPFAR and to ending HIV. So I want to ask all of you, and we can start with you, Tim, since you just brought this up, but if you had President Biden's ear and could ask for the administration to focus on one thing, what would that be? Sorry.
Sorry, did you ask somebody specific to that question first?
I was thinking Tim, but Anja, if you're ready.
Yeah, that's what I thought, but Tim, go ahead.
Actually, you go ahead, because I'm thinking of my answer.
So I think if I had the ear of President Biden, specifically around PEPFAR, I would have two messages, I think. First of all, somewhat similar to what Tim said, we have made a lot of progress in HIV, but obviously we are not there yet. And I think it would be really, really a big mistake to take the foot off the pedal, so to say, and to relax, because we've gone back, not forwards, and we really need to keep focusing on that. So PEPFAR, very important, and we also hope very soon to have a PEPFAR coordinator, which will help lead that section. So that would be really number one. The second one is that I really also would like to advocate for using the platform that PEPFAR already has built to address other issues. And for example, the COVID situation in the countries where we work, we do have people already on the ground. We do have people who are very good at training healthcare providers. We do have people who have experience in labs. So using that same platform to address there where the needs is the highest and help the countries to battle this, I think would be the second message that I had for President Biden. Thanks.
Lisa?
Yes. Well, I think if I had the honor of speaking to the president, I would urge him to support local manufacturing for COVID vaccines in every continent. I think we've seen that, everyone is at risk when every nation needs the ability to care for itself. And just some experience from, my time with Sumitomo Chemical over these decades. We have a bednet factory in Tanzania. And I know bednets are not as complex as mRNA vaccines, but people don't always realize that you can absolutely produce the highest quality products in the world and on the African continent. And I think there's a misperception if people don't understand that yet. So that would be number one. And number two would be pay the healthcare workers, pay the frontline healthcare workers so that those jobs have the dignity that they deserve. And that, I think, would fundamentally change the balance of activity.
Mm-hmm. And protect the healthcare workers, right? Especially in countries that don't have the vaccine yet, they should really get them first. Who's ready to go? Tim, are you ready now? Karl?
Yeah, sure.
Okay.
So I think I would suggest that he watches a recording of this session, and when he's considering sort of response to the pandemic, it's not just a knee-jerk response to dealing with COVID or the next pandemic, but it's showing a sort of more holistic view and an awareness that there's multiple other diseases out there that need to be taken into account and put in the equation and dealt together with pandemics.
Okay, and Karl?
3 points. One, I agree, vaccine leadership, and that could mean more globalized ability to manufacture and distribute vaccines, but clearly it means being at a collective table. He's already signaled that that's where the United States wants to be after, I would say, 4 years of walking away from those leadership tables globally. So vaccine leadership. Number two, based on my remarks earlier, fully fund our contribution to the effort of international family planning. That, I think, is a bedrock of global health progress, and that means, $1 billion or more for the USAID family planning account. The United States is the leader in family planning funding bilaterally. Even with reduced funding, we've still been the leader, but it's way underfunded. And number three, as Anja said, use the existing infrastructure, the structure that we've built with tax dollars already through things like President's Malaria Initiative, PEPFAR. Those are essential building blocks of global health delivery. You think about vaccine hesitancy and the risks that that poses in different parts of the world, and we see it in our own country. But think about this, PEPFAR for years has been dealing with things like circumcising adult males or dealing with injecting drug users. Some of the most sensitive, challenging aspects in global health. We know how to deal with those sensitive issues, turn those resources against the sensitivity around vaccine hesitancy too. Use the infrastructure we've built already.
Okay, we have a question here from a viewer. Hannah Wolfson is asking, how are you seeing organizations shift their strategies to be more inclusive of program beneficiaries throughout program startup to finish in response to COVID? For example, are young people being engaged in new and innovative ways during the COVID pandemic in ways that maybe they weren't previously engaged? Karl, that sounds like a good question for you.
Happy to try. Yeah, I think it's a long-term trend and one that needs to go faster for all of us. Our strategy at PSI has been for the last several years around what we call consumer-powered healthcare, and that's really starting from the insights that come from the consumer, the way we think of the person that we're working for in the global south. So that's really mining the insights, human-centered design, using all the modern principles that actually have ancient or older antecedents, but really being true to the power of understanding what it is that those we say we're trying to help really need, and letting them express and then help to design or lead the design of interventions. I think all of us need to do that. The pandemic has accelerated that, partly for the reasons that Anja pointed out. It turns out many of our programs can run with perhaps less direct supervision from a remote headquarters than we might have thought before. Again, the idea of putting more power in the hands of the consumer, I think, is fundamental to that idea that you can't design an effective development, let alone global health approach, without listening first and foremost, and really listening to the expectations of, or the needs, the desires of the consumer or the community. And there are strategies for doing that. We're trying to relearn those lessons after 50 years at PSI, where we started out dealing with meeting unmet consumer need in contraceptives. And we're still learning how to get good at that after 50 years. So I think all of us that's a permanent effort to get better at really understanding what is our consumer telling us about what's wrong in her life and how can we answer that. And there are lots of, I could go into much more detail, but the question's righteous.
Anybody want to add to that?
Sure. We actually have a group, we call them the Kayas. It's a community of African youth ambassadors that we work with to really inform and participate in our programs. They are 2 per country where we work, and they have often been youth who have benefited from our services or our programs, our psychosocial support groups, and they participate actively in our planning, our program designs, and one of them is also on our board, for example. So they also are being asked to look at tools that are being developed, or actually in some cases develop the tools themselves. So we really have made a structured effort to really include them in multiple touch points throughout what we do.
Okay. We just have about 5 minutes left. So I'd like to actually take a cue from all of your presentations and end on a very positive note. So I'd like each of you to answer what you think is sort of the best thing to have come out of the pandemic, and what's one thing that you wish won't go back to the way it was. And Karl, I'm going to start with you because you had a lot of positive thoughts. I'm sure you're ready for this one.
I do have a lot of positive thoughts in terms of what's happened in our programming, but I'm going to leave it with what's happening in my own institution, which is a real connection with resilience that I don't think we knew was there. A different way to get work done, a different way to draw energy from one another. None of us is going back to the old way of work after this. We're all moving into a hybrid, a way that I think will allow us to better take advantage of the talent we have globally across our 5,000 plus employees. That's exciting to me. I think that's really positive that comes out of COVID.
Okay. Anja?
Yeah, it's somewhat similar of what Karl said. I have really been impressed with the determination of our staff in finding ways to continue the work we do, continue to provide the services, and people really going the extra mile to come up with innovative ways to make sure that people continue these literally life-saving services. And I think that attitude, that shift of like, we can do things differently and we need to continue to look what's the best way of doing things. I hope that's one of the really positive things that stays with us, and that we really not go back to the old way, but are much more open to innovations and different ways of doing things.
Okay. Lisa?
Yeah, well, I agree with both of those points, and I guess I would add to it that I think it's really given us a push into a more integrated way of working. So, we've been talking about it since the whole Millennium Development Goals shifted into the Sustainable Development Goals, and all the, different health programs got kind of pushed together under the umbrella of universal health coverage. It's a very crowded goal, SDG number 3. There's a lot of activity, and I think until now it's been more of a uncomfortable jostling, but now it feels like there's real integration that's happening out of necessity. So I think that's a benefit.
Okay. And Tim, you get the last word.
Sure. Okay. Well, I think there's a lot of optimism to be gained from the fact that we've generated what seems like a pretty good series of vaccines in a very short time period. If we can do that for one disease, we can do it for other diseases if there's a will. I think it's just shown we can do more than we actually thought was possible. So yeah, that's what I think I take out of it.
Okay, well, I'll take the moderator's prerogative and add my own to that, which is to be able to have these kinds of webinars and have people have access to them from all over the world instead of needing to travel and needing to spend a lot of money that people don't often have to come to these things. So thank you all so much for your time and your knowledge and your experience and wisdom today. And I definitely learned a lot, and I'm sure all of our viewers did too. And thank you to Texas Biomed for organizing this webinar.